When people who obviously have peptic ulcer disease go to the doctor or go to their medical personnel in Nigeria, and it doesn't have to be a doctor. People go to varying levels of medical care, from the simple drugstore, when I call the chemist, to registered nurses, to unregistered nurses, to auxiliary nurses. We have levels, even to traditional medical people, and even their neighbors that seem to have expert opinion on these things. There's levels of medical care in Nigeria before they actually seek proper orthodox care, where at times they might be also eroded. Anyway, there is this misconception about diagnosis of peptic ulcers in Nigeria amongst even the populace, and people just believe when you go to your medical personnel and they tell you to bring stool for check, and if there's blood in it, it's 98% of the time they say you have ulcer. If there's no blood, oh, you don't have, even if you have obvious signs of peptic ulcer. I'm here to debunk that. I need you to understand that not all ulcers bleed, and not everything that bleeds in the gastrointestinal tract is ulcer. Using that as a yardstick for measurement for diagnosis of ulcer is outlandish and wrong. The few ulcers that bleed are those that the wounds cut across a vessel, a blood vessel. So they injure the blood vessel, you bleed. And you can see that in the stool where you do your cord blood check. And this is just an infinitesimal aspect of the incidence of peptic ulcers. I'm here to tell you. Going to check stool or cord blood as a yardstick for diagnosis of peptic ulcer is wrong. It could be an adjunct. In fact, it is something that is treated in most cases empirically, like in the rural areas, like where me I practice, have my clinic. You don't have the resources to do the gold standard of diagnosis. You find out that most people with gastritis, gastroesophageal reflux disease, stomach ulcer, duodenal ulcers, all these spectra of similar diseases, anybody that has it would tend to have what we call epigastric tenderness. Epigastrium is the upper part of the abdomen, just below your breast, where the stomach and where the abdomen sinks in from the chest, and which is where I'm pointing now if you're watching. And that's the epigastrium. Majority of everybody that has any of these diseases, which I will group as peptic ulcer, will have pain when you push down here. Even if they do it to themselves, they will wince. If you do it to them, they will pull your hands away. If somebody doesn't have it, that person is unlikely to have peptic ulcer disease. We are dealing with science, but we're dealing with nature too. There are people who are aberrations to the norm. But I'm saying majority, almost 99%. In those places, that's just all you need to do to diagnose, because you don't have the ability to resort to doing endoscopy, barium swallows, and all that you can use to as adjuncts to diagnosis. But most times it's just a clinical thing. Whether they have blood in their stool or not, it does not matter. If you're actually bleeding from an ulcer, that is dangerous, because ulcer concentrates mostly in the upper abdomen. For you to have I'm talking about fresh blood, you're bleeding fresh blood all the way from up here, and you're passing fresh blood, you'll be collapsed, you'll be comatose, you'll be almost moribund. It's an emergency. I want to also tell some of you that wake up and they see fresh blood in their stool, or when they wipe after defecating. Most times, fresh blood is benign, especially amongst young people. When you have like people in their 60s and all that, you might be a little careful in just dismissing it. But most times, fresh blood per rectum, especially if you are not collapsed or comatose or hemodynamically unstable, it tends to be benign. When I say benign, in medicine means something that is not serious or something that is not life-threatening. Like it could be because of hemorrhoids, what we call piles in Nigeria. It could also be because of hard stool that just scraped you, giving you fresh wound. It's usually something around the anal region. It could be maybe fistula. Fresh blood tends to just have come out from almost outside there, and usually not a serious condition. Just saying, for those of you that have experienced that, especially in the absence of any hemodynamic instability. But if you have a peptic ulcer that is bleeding, we've seen it here, that person will be, you need immediate transfusion of blood, all those medications we have here, trotyne, and most times it's seen mostly in alcoholics that have had liver diseases and other, and what we call variceal bleed and varices. You see somebody that goes to the doctor with obvious symptoms of ulcer, and they are ruled out from having ulcer just because they didn't have positive blood tests in the stool. I'm here to tell you, it is wrong. You should be empowered enough to know, yes, you have it. All you need to do, put your hands there, press. If you have pain there, then you should go back and discuss with your medical personnel to reconsider. I mean, the gold standard for peptic ulcer diagnosis is endoscopy, where they put a camera down through your mouth to go and see it clearly. You can't even wish for something better. Below that is what we call barium swallow, where they give you something like white, contrast material, white substance to drink, barium. You drink it, and when you're drinking, they take a picture, x-ray, plain x-ray, and see if you have an ulcer. There should be a defect, because the ulcer is like a puddle of the kind of potholes we have in Nigerian roads, right? So when you have a pothole, right, and there's rain, even when the other smooth part of the road have dried up, you see puddle of water staying in the pothole for days. That's how the peptic ulcer. So if you drink the barium, it will slide down on other places. But if there's that place you have an ulcer, which is a wound with opening, then the barium will fill it up. When you take picture, you see what we call barium defect. So that's what we use. I think we still use that in parts of Nigeria. I don't know if you think we don't use barium swallow here anymore. They do endoscopy, which is easy. I know they do endoscopy in Nigeria too. But that's the gold standard if you are concerned for diagnosis. Otherwise, you just treat empirically. Well, if you're a doctor, you're a medical personnel, somebody comes with all those bloating and all those signs, and you press here, they are tender. Well, what else are you looking for? Unless they don't respond to your PPIs, your antacids, and your maybe antispasmodics, then after a while, then you can go to the next stage of diagnosis. Whilst talking about peptic ulcer, I cannot fail to mention H. pylori. This is sounding ominous already. A lot of people get scared over there because they've been told that they have H. pylori. In fact, almost everybody with ulcer there, they keep looking for H. pylori, as if it is this boogeyman. It's not as bad as they make it sound. H. pylori stands for Helicobacter pylori. So H. pylori seems to live in the GI tract, and it can give you gastritis, which is irritation of the stomach lining, and that can also go ahead to predispose you to ulceration, full ulceration, or you can just have a gastritis. But all of them give you the same symptoms: bloating, pain, and all that. As a bacterium, it is treated with antibiotics. That is the only difference, because peptic ulcer per se is not treated with antibiotics. But when Helicobacter pylori is implicated, then you got to eradicate it with 2 weeks of antibiotics. That is a combination of 2 different classes. And then at the same time, you continue with your PPIs, which are the proton pump inhibitors, so this for 2 weeks, and then after that you continue with your prazoles as other people with ulcer. They make this hand openers when you go and then there's also a misdiagnosis here. H. pylori is a GI tract organism. It acts locally, but it can give you, once anything invades your body system, it's called an antigen. Any foreign organism that goes into your body. So your body, by the way God made it, will build up resistance against it and produce antibodies. The initial set of antibodies, the IgM, big, like tall. When there's a fight, somebody brings a fight to your village, they will send the big men, the 7-footers, to go and fight before the little ones will come and clean up the spoils later. When you have an antigen going, the big antibodies called IgM will be the ones to be produced initially to fight. After they finish fighting, then the IgG, which is small antibodies, the IgM will depict an acute phase of anything, while IgG most times will depict the chronic phase, like latent phase, or when you have recovered, or when you have immunity, except of course in hepatitis C and HIV, where the antibodies will actually depict a state of infection. This is what happens in H. pylori infection. When they come in, the gut, they make your body to build antibodies. Of course, antibodies circulate in the bloodstream, and that's the products of B lymphocytes, they circulate, while the cellular ones stay in the cells. When you get a blood drawn to check for H. pylori, you're actually checking the antibody to it. You're not checking the acute infection or active infection. Doing blood tests for H. pylori is misleading, because you could have had that H. pylori 10 years ago, but the circulating antibodies are still there to protect you. You're actually protected, and somebody is treating you. That is how they diagnose them over there. I have an issue with that. Somebody is doing a blood test on you and telling you that you have H. pylori and you need to be treated. It is wrong. Are you listening? It's wrong. Remember, this lecture is for my people over there. People in the US where I practice and in the Western world, they know this. To actually treat for H. pylori, you have to either check the stool, test it for the organism, the H. pylori, or during endoscopy to diagnose an ulcer, which you will see, they take a biopsy, and part of the biopsy they will culture to see if there's H. pylori. If there's none there, they don't treat for it. That person may have been exposed years ago, recovered, and has circulating antibodies that provide immunity, and you're treating. It's wrong. That is why we do not use blood tests here to check for H. pylori, and that is what they use over there. I'm telling you, it's not as most of you, I don't know the exact statistics, but it could be up to 90% of those of you treated for H. pylori don't even have it. You had the infection in the past, you now have circulating antibodies that protect you, and they are treating you. Maybe no harm done. But the problem is that where I have issue with this is that most people dwell on this. They call me up, H. pylori, diagnose. How did they diagnose you? Some even make the mistake because they will still check their stool for occult blood, and they see any semblance of blood. Oh, you have ulcer. These combination can be deleterious. So you have to sift through this. When some people, when they check their blood for occult blood, I think they are even checking. When I said, did they check your stool for H. pylori? No, they checked my stool because they don't give them the results. People pay for results. I don't get it. You go to a medical personnel, all the results, X-ray, ultrasound, CT scan, blood test, are paid by you. And your medical personnel keeps it with him. He paid nothing. You are entitled to a copy of your results so that you can take it to somewhere else and seek care. Or you can do an adjunct test and compare. This is also something I'm going to address in one of my teachings. Please ask for a copy of your results. You're entitled. In fact, actually, you are supposed to have the original. The medical personnel is supposed to keep a copy. You can take your original to some other facility. Let's say if you got worse and they need to compare the previous data to this current data. I'm educating you on that. Ask for your results. Because anybody that calls me here to say, I say, go and get it. It's your, you paid for it. It's yours, by the way. Anyway, I asked them, I was digressing a bit. When I asked them, oh, did they do stool tests? Yes. The only stool test they're doing is to check for alcohol blood anyway. And people are being treated. I mean, these things are exorbitant anyway. They're going to, and you don't even need an injection. For those of you who love your injections, there's really no need for injection here. Just the real ones that have it. 2 weeks of combined antibiotics, 2 combined antibiotics, and then proton pump inhibitor, and then you should eradicate it. Of course, it doesn't mean you will not have symptoms of ulcer. Ulcer is a wound. So if you have a wound on your skin and you're scraping each time, every morning you come and touch it, every morning you come, it's not going to heal. Or maybe if it heals, you scrape it again. So that's how it is. Peptic ulcers are tough to heal because you're always eating. Your stomach is churning the food and it's still scraping it, even if it's healed to an extent. There's a belief that if you take these medications straight for 2 months with proton pump inhibitors or even H2 receptor blockers, and you take antispasmodics at times, you take antacids, you do your dietary modifications, for straight 2 months you are likely to heal. It's happened in most people. But it's like a saying in my place, there's an adage in our place that if you cure somebody of madness, you haven't cured that person of muttering. So that's how the peptic ulcer is. It's likely to, exacerbate some other time because maybe you ate so much like hot food that burnt it or something, or like you ate food that you didn't chew, whether your stomach was churning it and scraping it. It could rear its ugly head again. Then you still have to, you take your medicine. And there are people who take the medicine every day, especially those who have hyperacidity that have specific causes. So that's what I'm trying to educate you. Like some people say, oh, they've taken medications. So you just have to have it around you. If you start having symptoms, you take it. And, it's a healing takes time, especially if you are still touching it, if you are still grating it, causing more friction. Open up the wound again. It still has to take time to heal. And that's about that. The main things I wanted to bring out here is that just empirical diagnosis in rural areas or places that you cannot have access to proper gold standard diagnosis is enough for you to treat. And you don't have to start looking for blood in the stool. It doesn't even make sense. Because most of the things that cause bleeding, hemorrhoids, fistula, constipation, which has to even colon cancers, intravenous malformations, polyps, bleeding. These are things that way ahead of it in causing bleeding, and also like in alcoholic varicose bleedings. These things are ahead of it. Using that to diagnose is wrong. And I have told you how you might have to treat recurrently. For those of you who are asking me, doesn't it heal? Yes, it can heal. And there are people who just heal. They say, if it's assumed if you take the medicines for straight 2 months, you could heal. But you could still scrape it in future. But you might not need to take medications for long and it heals again. It's a wound. The skin wounds take about 5 to maybe 10, 15 days to heal, even without you scraping it. What less? The other area. That's basically what I wanted to talk to you about ulcers. If you have any further questions, you can chat, you can share, you can contact me, and we'll go from there. Thank you very much. This is your favorite doctor from New York City saying to you, get empowered. Thank you.